All right, let's begin with depolarization of the SA node. So we know that depolarization occurs here at the SA node. And at this SA node, you have cells that have different gates that open and close. So here we have the resting membrane potential. And once it hits about negative 55 millivolts, then we will have a depolarization occur, which basically means that the sodium gate opens and sodium rushes in the cell, and depolarization occurs here. At the top here, we have the sodium gate closing, and the potassium gate opens within the cell. And then a potassium efflux occurs, which is repolarizing or hyperpolarizing the cell. So like I said, this occurs at the SA node to start. And the depolarization goes from cell to cell through the intercalated discs through the heart. So we can kind of see this trickle in 360 degrees all across the atrium until it hits right here, the layer of dead cells, and the depolarization happens here at the AV node. Excuse me, yes, the AV node. So then the AV node is depolarized, and it is sent down the bundle of His, and then sent down the left and right bundle branches, all the way down, and then back up through the Purkinje fibers. This is where we see our heart squeeze the top to bottom up, or top down, bottom up method. But for force to be generated, we have to have calcium bind to troponin C within the T-tubules. So here is a T-tubule, and we have calcium sensing feet. So these calcium sensing feet detect the calcium and release it from the sarcoplasmic reticulum. It then binds to troponin C and shifts troponin I. And tropomyosin moves so myosin can grab actin. ADP is then released, and we can see that 50% of that stroke is done. Inorganic phosphate gets dropped off, the other half of the stroke is complete. One full myosin head is then pulled and does it again. ATP then binds to myosin head and releases myosin from actin, and then myosin grabs actin again if calcium is present, again to bind to that troponin C. So we can kind of see this as a, grab the rope, release method. We also can talk about here HFrEF and HFpEF. So HFrEF is systolic heart failure. So we can see that right here. So HFrEF is also referred to as heart failure with a reduced ejection fraction. Here there's an inability to eject the blood, so leaving blood in the ventricle, which also leads to an increase of preload. And we know that there's an asterisk to the Frank-Starling mechanism, right? The greater the stretch, the greater the squeeze, to a point. If the sarcomeres are overstretched, they won't be able to create that force as well. So when this occurs, the heart then compensates by adding sarcomeres in series. So this is the main issue here we see in HFrEF. The heart remodels the ventricle by doing this, and by adding sarcomeres in series, the ventricle is dilated, it's overstretched, and there's a less force that is created for contraction. Now, for HFpEF, which we can see here, is also known as diastolic heart failure, and this is where there's an impaired ventricular filling. So this is due to a decrease in compliance or uncontrolled hypertension, and as a result, the ventricle wall thickens, which you can see right here. So it thickens as sarcomeres add in parallel to one another. The ventricles are less flexible and decrease the amount it can fill with blood. The heart tries to compensate by decreasing preload or increasing heart rate. However, it doesn't give the heart enough time to fill with an increased heart rate, leaving the heart to work even harder. So hypertrophic cardiomyopathy occurs, or basically growth of the heart tissue as a result. So how are we able to detect HFrEF and HFpEF? So one way is through the echocardiograms. So this is used through a Doppler, and it's basically used to visualize HFrEF or HFpEF. Using sound waves through the Doppler, you can actually see the heart structures. And we use it to look at the heart motion as well. It is used to measure the thickness of the ventricular walls as well as the left ventricular size. So this is why it's a great way to especially detect HFpEF and the thickness of that wall, or here in HFrEF as well. And this is an image of the echocardiogram in HFrEF and PEF. Another way is MRI. So MRI is great at capturing soft tissue. And we know, of course, the heart is made out of soft tissue. So MRI can also be recommended for HFrEF and HFpEF. Now in this structure, they used the echocardiogram as well as the MRI to get images. But the MRI can show if the heart muscle is dead or alive and can calculate the patient's ejection fraction. Overall, both of these modalities help us visualize heart compensation along with the heart failure.